All right, team, let's get into it. Welcome to your ultimate rapid review for the MRCEM Primary. Seriously, think of this as me, a senior examiner, giving you the final high-yield briefing right before you walk into that exam hall. We're going to cut through all the noise and just hit the absolute must-know facts. No fluff, just what you need to get over that finish line.
So here's our game plan. We are going to blitz through 5 key areas. First, we'll tackle the anatomy of the torso. Then we'll dive into core neurology. After that, it's all about landmarks in the extremities and abdomen, followed by some absolutely essential physiology and pharmacology. And we'll wrap it all up with a rapid-fire round on clinical syndromes. The whole point here is speed and locking in those exam triggers. You ready? Let's do this.
Okay, first up, the thorax. You know examiners absolutely love this area, and for good reason. It is jam-packed with vital structures all crammed into a tiny space. One little injury can cause huge problems, so you have to know exactly what's where.
Right, let's kick off with a trauma scenario you are almost guaranteed to see. A patient is brought in, stab wound, mid-clavicular line, 4th intercostal space. Before you even think about anything else, what major structure is sitting right in the line of fire? What's most likely to be hit?
It's the right ventricle, and the reason is simple anatomy. The RV isn't hidden away in the back, it's right up front, making up most of the anterior surface of the heart. So any trauma to the front of the chest, whether it's blunt or penetrating, puts that right ventricle at huge risk. You gotta lock that in.
Now this is basically an anatomical cheat code. It's the transverse thoracic plane, right at the T4/T5 level. Examiners are obsessed with this landmark because a ton of critical events happen right here. You've got the trachea splitting into 2, the aortic arch starting and ending, the azygos vein dumping into the SVC, and it's the line that divides the superior and inferior mediastinum. Know this plane and you've just answered like 5 potential questions.
Okay, let's clear up a common point of confusion, the coronary arteries. The LAD, the left anterior descending, you've probably heard it called the widowmaker. It supplies the front 2/3 of that interventricular septum and the anterior wall of the left ventricle. Meanwhile, the PDA, the posterior descending artery, handles the back third of the septum and the posterior walls. Getting this straight is absolutely key for interpreting ECGs and understanding infarct patterns.
All right, let's shift gears and move on up to neurology. We're going to do a high-speed tour all the way from the cranial nerves down to the spinal cord. Really pay attention to the pathways and those classic presentations when something goes wrong.
Here's another exam favorite. Just picture this. A pituitary tumor is growing, and it starts pressing right on the optic chiasm. What is the specific textbook visual field defect that you are going to see in that patient?
Bitemporal hemianopia. This is really just a pure anatomy question dressed up in clinical clothes. So the optic chiasm is that crossroads where the nasal retinal fibers, the ones that see your peripheral or temporal vision, cross over. So if you compress that chiasm, you knock out those crossing fibers from both eyes and boom, the patient loses their peripheral vision on both sides. It's literally like they're wearing blinders.
Okay, this is a procedural map you just have to know cold. When you're doing a lumbar puncture, you pass through these layers in this exact order. Skin, supraspinous ligament, interspinous ligament, ligamentum flavum, you'll feel a pop. Then you go through the epidural space, and finally, you pierce the dura and arachnoid mater to get that sweet, sweet CSF from the subarachnoid space. Just know the sequence.
This table right here is pure exam gold. I can pretty much guarantee these 3 syndromes will show up. For Brown C-cord, think of a clean slice through half the cord. You lose motor and proprioception on the same side, but pain and temperature on the opposite side. For anterior cord, you lose motor, pain, and temp on both sides, but proprioception is fine because the back part is okay. And for central cord, just remember that cape-like pattern, where the motor loss is way worse in the arms than in the legs.
Okay, let's keep this pace up. We're moving down into the limbs and the abdomen. And again, we're just focusing on those high-yield injuries and anatomical relationships that get tested all the time.
If you see the words foot drop in a question, your mind needs to immediately jump to the common peroneal nerve. It's just so vulnerable as it wraps around the neck of the fibula. I mean, a simple fracture, even just sitting with your legs crossed for too long can knock it out. And that leads to the classic inability to lift the foot up, loss of feeling on the top of the foot, and weak eversion. This is a gift of a question on the exam, truly.
You absolutely need a quick way to remember which abdominal organs are tucked away in the back, in that retroperitoneal space. The mnemonic is sad pucker. Just burn it in your brain. Suprarenals, aorta/IVC, duodenum, pancreas, ureters, colon, kidneys,
esophagus, and rectum. It'll save you so much time on a question about, say, a CT scan after trauma.
And here is a red flag safety fact you cannot forget. In an adult, the spinal cord itself ends around the L1/L2 level. So to be safe, you always perform a lumbar puncture lower at L3/L4 or L4/L5. You're aiming for the cauda equina, where the nerves are just floating around like spaghetti and can be pushed aside. You stick that needle too high and you risk a catastrophic spinal cord injury. Don't be that person.
All right, time to switch gears. Now we're getting into the how and the why. We're looking at the physiological processes and drug mechanisms that are the bedrock of emergency medicine. This is where you connect all that anatomy to how the body actually functions. The oxygen dissociation curve is something you just have to be fluent in. But don't overcomplicate it. Just remember this. A shift to the right means release. When your tissues are working hard, they get hot, they get acidic, they produce 2,3-DPG, hemoglobin lets go of oxygen more easily to feed those tissues. The opposite conditions, plus fetal hemoglobin, cause a shift to the left, where hemoglobin hangs onto that oxygen much more tightly.
Let's talk about flecainide for a second. You'll see it on the list as a Vaughan-Williams Class 1C antiarrhythmic. Okay, great, that's what it is. But the exam is going to ask you how it works. What does it actually do?
And here's the breakdown. Flecainide is a really potent blocker of the fast sodium channels in the heart cells. So it dramatically slows down phase 0 of the action potential, that initial super fast upstroke. But the key thing to remember for Class 1C agents is that while it slams the brakes on that initial depolarization, it has very little effect on how long the total action potential lasts.
Okay, final section. We are in the home stretch. This is all about pattern recognition. When you see a certain set of signs and symptoms, your brain needs to make that immediate leap to the right diagnosis. So let's do a few quick ones. You see this triad? You think Horner syndrome. End of story. Ptosis, meiosis, and anhidrosis. A droopy eyelid, a tiny pupil, and no sweating on one side of the face. This is a dead giveaway that there's damage to the sympathetic nerve supply to the head. The cause could be anything from a lung tumor at the apex to a carotid artery dissection.
Now, this is a diagnosis you absolutely cannot afford to miss. Ludwig's angina has nothing to do with your heart. It's a crazy fast-spreading cellulitis on the floor of the mouth, usually started by an infected tooth. And why is it so deadly? Because all that swelling can push the tongue up and back and completely block off the airway. This is a true drop-everything airway emergency.
For a high anion gap metabolic acidosis, you need that mud piles mnemonic. We're just highlighting 3 of the big players here. Methanol, from someone drinking something they shouldn't have, uremia, from kidney failure, and of course, diabetic ketoacidosis, or DKA. You will see these constantly in the ED, and knowing the causes helps you start hunting for the right one.
And for our last one, let's put it all together. This is the classic textbook emergency presentation. High fever, a stiff neck, and a particular rash that doesn't go away when you press a glass on it. What organism should be screaming in your head as the most likely cause for this life-threatening situation? Think about it. You know this. Nailing this stuff is what gets you through that exam. Good luck.